Welcome back to the deep dive, where we streamline complex research, extract the crucial nuggets, and give you the absolute shortest path to being well informed.
Today, we're digging into something I think is incredibly important.
It really is. We're tackling how to customize preventive oral health care for individuals with special healthcare needs, or SHCN.
Yeah, and this is a critical discussion because it really shifts the entire paradigm of clinical care.
So when the source material talks about a compromised individual, what exactly are we talking about?
It's a broad term. They mean someone with, physical, medical, mental, or emotional limitations, things that affect their ability to function normally in daily life.
I see. So these limitations would redefine pretty much every step of the dental process.
Every single step, from just communication all the way to technique.
Right. So it's not just about standard treatment, it's about prevention being fundamentally customized. Our mission today is to uncover how dental professionals assess a patient's actual capability.
Not just their need, which is a key distinction.
Exactly. And how they adapt education, tools, and maintenance to prevent serious infection and avoid, extensive procedures that these patients might not even tolerate. It's a framework built entirely on adaptation.
That's the perfect word for it.
Okay, let's unpack this using the source material, starting with what has to be the most immediate universal hurdle: communication and sensory perception.
Communication is the bedrock of any successful behavioral change. I mean, especially
Yeah.
when you're trying to instill daily hygiene habits.
Sure.
But for this population, that whole process is often compromised right from the start because of sensory impairment, whether it's vision, hearing, or speech.
Let's start with visual deficits. I imagine that can range from something like high sensitivity to glare all the way to total blindness.
It does, and simple modifications are paramount. If a patient is light sensitive, we're talking about giving them sunglasses, being really careful with the operatory light so it's not in their eyes.
And for instruction, you can't just hand them a standard pamphlet.
No, you can't rely on small print or standard diagrams at all. You have to lean heavily on high-contrast visual aids. So think large instructional sheets with bold black lettering or oversized models to actually demonstrate brushing and flossing.
Okay, but this is where it gets really interesting for me. What about a patient who is completely blind? If you can't show them success, how do you teach it?
That's where you have to redefine what success even means. For the totally blind, success isn't seeing a mouth free of plaque.
So what is it?
It's the patient being sensitized to the feeling and the smell of a clean mouth.
Wow. So you're teaching them to recognize the difference between a rough surface and a smooth, slippery one?
Exactly. That tactile feedback, that smooth feeling on the tooth after brushing compared to the kind of rough, fuzzy feeling of plaque, that becomes the measure of success that they can internalize.
That is a profound shift in methodology. Okay, let's move to hearing disabilities. The primary rule here, and the source material is very clear on this, is actually counterintuitive for a lot of people.
It really is. Never shout.
Right, and people's first instinct is always to get louder.
And that's crucial because for many types of hearing loss, those loud, high-frequency sounds just distort the message. It actually makes it harder to process.
So the goal is clarity, not volume. You have to be face-to-face at eye level and remove your face mask.
Absolutely, to help with lip reading. And beyond the verbal stuff, demonstration becomes key. A clinician might use pantomime to show the action, and then the patient should immediately try to repeat it on a model or their own mouth.
To make sure the skill actually transfers.
You got it. To confirm it landed.
And there's a practical tip here for when you're actually doing the work. You have to turn off or remove the patient's hearing aids.
Yes, because the high-pitched sound from a handpiece, or even just being close to the clinician's body, can cause that loud feedback squeal, which can be really unpleasant or even painful.
Okay, last in this section is speech and language disorders. This would cover things like aphasia after a stroke, or dysarthria, which affects muscle control for speech.
Right, like you might see with cerebral palsy or other neuromuscular diseases.
So when verbal communication is compromised, we're back to relying heavily on visual aids.
We are. It might mean written communication, using lapboards with pre-printed letters or pictures, or just a lot of visual pedagogy pictures of the procedure, or the steps for hygiene.
But the source material says maybe the most important takeaway here is about nonverbal connection.
Absolutely. Even when words fail, a genuine smile, holding a hand, a touch on the shoulder, those nonverbal cues become the primary way to build trust and convey comfort.
Okay, so once we've established how they receive information, their sensory and communication needs, the next challenge is purely cognitive. This brings us to segment 2, tailoring instruction to cognitive capacities.
And this is where we have to figure out how complex the lesson can be. The clinician has to gauge the patient's cognitive level.
What does that mean, like their attention span?
Their attention span, their ability to understand, their memory for details. You can usually get a sense of this just by asking some clear, simple questions.
And that assessment then dictates everything else.
It dictates the vocabulary you use, how complex the instructions are, and even what kind of reward system might work for them.
And for cognitively impaired patients, the source material insists that a task like toothbrushing, which seems simple to us, has to be just dismantled into tiny, discrete steps.
Precisely. You can't give them 5 instructions at once.
Yeah.
And there are big differences based on the severity of the impairment.
So what does that look like for someone with, say, mild or moderate impairment?
For them, the classic tell, show, do approach works very well, especially with pictures and modeling. After some repetitive training, they can often successfully use an automatic toothbrush and even manage different techniques, like a scrub or a circular method.
But the severely impaired would need a completely different approach.
A completely different approach. Patients with severe impairment are often limited to the most basic gross motor skills. We're talking push-pull or scrub motions.
And they might not even be able to do that for their whole mouth.
They might struggle, yeah. They may only be able to isolate brushing to one side or one specific area. So you're looking for partial success and just maintaining that, rather than trying to achieve full mastery.
Which means the instructional recommendations are all about frequency and brevity.
Short sessions, lots of repetition, simple language, immediate positive feedback, and then reminders for homework. Maybe a written checklist or an audio recording.
And all of this really hinges on the caregiver, doesn't it? The source material details 5 categories of caregiver support.
Yes, 5 critical categories.
Mm-hmm.
And it ranges from no assistance at all to complete dependence.
Okay, let's walk through those because I think the nuance is important. We know independent means no help required. What's the next level down?
The next level is standby assistance. Here, the patient can do all the tasks, but the caregiver needs to be right there, ready to offer a cue or step in if they lose balance or attention.
Okay, so they're on standby. And then after that?
Then you have partial assistance. The patient does most of the activity, but the caregiver helps with, say, 25% of the effort, maybe helping with tricky areas or putting the toothpaste on.
That makes sense. It's a shared responsibility. And then we get to the higher dependence categories.
That's right. Next is active assistance. Here, the patient is only doing about half the task, or even less. The caregiver is actively involved, physically completing several steps of the process.
And the final, highest level is complete staff dependence. What does that look like in practice?
It requires significant physical management. This could mean the caregiver needs to use specific techniques like head stabilization, retracting the lips, applying pressure to the jaw to keep the mouth open. It can be complex, sometimes even needing more than one person to assist properly.
Wow, that's a huge commitment. Okay, so once we've figured out how they think and learn, the next challenge is purely physical. This takes us to segment 3, functional performance and equipment modification.
Right, functional performance is all about the mechanics. A lot of disabilities, arthritis, cerebral palsy, they can adversely affect the fine and gross motor skills you need for brushing and flossing.
So if a patient has poor dexterity, where do you even start with modifying something like a toothbrush?
For gross motor control, you focus on the grip. We can use simple orthotic appliances to help them grasp the handle. But the real genius I found in the source material is about custom sizing that handle.
What do you mean?
The clinician should actually assess the patient's strongest grip diameter by having them grasp the clinician's fingers.
Wait, so you're not just guessing a good size, you're physically measuring their optimal strength point to customize the tool.
Precisely. If their strongest grasp is, say, the diameter of 2 of my fingers, then we're going to build up the toothbrush handle to match that exact size. It just improves their mechanical advantage so much.
That's brilliant. And how do you assess range of motion for the elbow and shoulder?
A great initial question is, can you feed yourself? If they struggle and use special adaptive utensils, you ask them to bring those in.
Oh, I see. So if they can get that utensil to their mouth.
We can modify the oral hygiene aids, maybe angle the head or lengthen the handle to match the angles they can already achieve with their feeding devices.
That's such an intelligent adaptation. And the source material lists a bunch of easy ways to build up a toothbrush handle using everyday material.
Right. The principles of brushing don't change, but the handle has to be modified. You can increase the dimension quickly with things like foam hair rollers, bicycle grips. You can even stick the handle in a tennis ball to stabilize the grip.
And what about electric toothbrushes? They seem like an obvious solution for poor dexterity.
They are useful, but with a big caveat. They're especially good for patients who can grasp and place the brush, but just lack the fine motor skills for the actual cleaning movements.
Yet!
But they aren't inherently superior to manual brushing, and the weight of the battery pack can still be a problem for patients with significant weakness.
And for flossing, the guidance is pretty strict.
Very strict. It's not recommended unless the patient has already mastered toothbrushing. If you need to clean between the teeth, you move straight to specific devices.
Like floss holders or interproximal brushes?
Exactly. Especially where you see some gingival recession, those little brushes work really well.
Okay, let's touch on specialized patient management equipment. This is about safety and access. Mouth props, for instance.
Mouth props are essential. They help open and hold the mouth, and crucially, they protect the caregiver's fingers from being accidentally bitten. You can get custom ones or even make simple ones from tongue blades and gauze.
And stabilization devices.
Headrests are key for support, especially for patients with involuntary movements. For flailing limbs, soft ties are mentioned. And it's so important to emphasize these are not punitive restraints.
They're for stability.
For stability and security. Positive support.
And that brings up a massive point from the sources. The limitations of full-body wraps, like the pedo wrap or a papoose board.
A huge point. While those devices are sometimes used for immobilizing smaller adults during treatment like filling a cavity, their usefulness is highly limited in preventive programs.
Why is that?
Because the entire goal of prevention is active patient involvement and cooperation, and restrictive immobilization directly undermines that goal.
That distinction, active participation versus passive restraint, is key. It leads us right into our final segment on preventive therapies and long-term maintenance. Let's start with diet.
Foundational. The goal is a strict reduction of cardiogenic potential. That means restricting between meal snacking entirely. If sweets are going to be consumed, they have to be at mealtime, and teeth have to be brushed immediately after.
And bedtime snacking is a definite no. Since compliance often relies on rewards, we need alternative systems.
Exactly, using things like toys or non-curious foods or outings as rewards instead of sugar.
Moving to chemical prevention, sealants are a big one.
Highly effective, and a great practical tip for placing them. Seat the patient upright, not reclining. It helps so much with moisture control, especially if saliva management is an issue.
And fluorides. We know regular topical applications by staff are vital. Fluoride varnish seems to be the best option here.
Absolutely. Varnish is great because you can paint it on quickly, and it works even in a moist field. But here's the crucial contraindication for home use. Rinses and gels are unsafe for compromised patients.
Because of the risk of swallowing them.
Exactly. So instead, the alternative for home fluoride is using a foam applicator.
Okay. And for long-term maintenance, what tools are indispensable?
Disclosing techniques are highly suggested. It helps visualize the plaque when removal is difficult. You can use solutions or tablets, but honestly, the easiest and most visually accessible option is just commercial red food coloring.
It provides a great contrast.
The best. And because patient dexterity is so often limited, chemical plaque control is highly needed.
Since it relies less on fine motor skills.
Right. Swabbing with something like chlorhexidine is a robust, dexterity-independent way to help manage plaque. It's a vital supplement.
Finally, the recall schedule. I'm guessing it's more frequent.
Much more frequent. Compromised individuals have a higher incidence of caries and periodontal problems, so they need to be seen more often. But that frequency has to be highly individualized.
Based on what?
Based on their health status, their actual disease rate, and crucially, the caregiver's ability to consistently maintain that home care. It's a continuous, personalized cycle of assessment and support.
This whole deep dive really reinforces that effective preventive care for these individuals isn't about one trick or one tool. It requires establishing complete cooperation.
It's a team effort among the family or caregiver, the health provider, and the patient to whatever extent is possible.
It really is an ongoing process of assessment and adaptation built on those three pillars you mentioned.
Sensory, cognitive, and functional performance.
And this brings us back to that ethical and practical tension we touched on earlier. The sources mention that certain restrictive devices have limited usefulness when the goal is actively involving the patient in their own hygiene.
It's a real dilemma.
It all comes down to this core tension. When we rely on devices for immediate stability and professional effectiveness, how do we make sure we're not sacrificing the patient's long-term independence and their own personal achievement in their oral health?
That is a constant balance every clinician and every caregiver has to chew on.